Welcome to Third Rock Ultrasound, where our mission is to help providers integrate ultrasound technology into their patient care. The Pediatric Ultrasound course provides a foundation for life-saving diagnostic ultrasound and procedural guidance in a pediatric population. This is Module 1, an Introduction to Pediatric Ultrasound.
Hi, I'm Tom Cook.
And I'm Jeff Hayden, and this is the Pediatric Ultrasound course from Third Rock Ultrasound.
Let's begin our introductory lecture with a brief history of ultrasound and carry that through the earliest applications of pediatric ultrasound and point-of-care ultrasound. Note that clinical ultrasound, point-of-care ultrasound, bedside ultrasound, and emergency ultrasound may be used interchangeably in the subsequent lectures. These all describe what we as clinicians perform at the bedside for our patients. Third Rock Ultrasound would like to give a special thanks to Dr. Joseph Wu for his permission to use the historical pictures of ultrasound systems in this presentation. For more information about Dr. Wu's work on the history of obstetrical ultrasound, please see the URL at the bottom of the screen. Over the last 2 decades, point-of-care ultrasound has become a huge trend in the evaluation and management of patients at the bedside and other settings. This has not been limited to the United States and in fact has had a worldwide impact. Third Rock Ultrasound continues this worldwide trend. Founded in 1998 with a mission to teach the valuable skills of bedside sonography, Third Rock Ultrasound courses have been presented over 1,000 times in 8 different countries in 3 different languages. Our access to this life-saving technology is due to a series of events that began in the late 19th century. Pierre Curie, seen here with his wife Marie Curie, is credited as the first person to describe the electric potential of crystals when subjected to certain forces such as an electrical current. This process produced ultrasonic waves, which became known as the piezoelectric effect. Early uses of this form of ultrasound generation included development of the first sonar devices used by the submarines in World War I. It was not until the 1940s, however, that ultrasound was utilized in medicine. Now, the first ultrasound machines were huge. They were large and difficult to use. These early machines used vacuum tubes and electric wiring. Many early machines used water baths as a method to send ultrasound into the body. On the left, you can see how a bag of water is lowered onto the patient's body to perform the exam. Now on the right, you can see the person is submerged into a tub of water that transmits the ultrasound signal to the patient. During the 1950s, the public began to see medical ultrasound for the first time. The image on the right is from the very popular Life magazine and has the caption, "Sound Wave Portrait of the Flesh." The images generated at that time were of course quite crude by today's standards. Do you have any idea what this image from the 1950s might be? Now take another look. Here's a similar image from a study done around 1970. We can now see findings suggestive of an obstetric ultrasound. Although ultrasound did not use radiation, specialists in radiology began to use it for imaging in the 1950s. In the 1960s, cardiologists began to use ultrasound to image the heart, and then in the 1970s, obstetricians integrated ultrasound into their specialty. However, for the most part, there was a lag in time before other specialties began to use ultrasound at the bedside. So why were radiology, cardiology, and obstetrics the initial specialties to use this technology in medicine? The easy answer is because they needed it. Radiologists in the 1950s and 60s only had plain films as a method of imaging the human body. It would be decades before CT and MRI would be available. Cardiology could not use X-ray to image the heart for information on how well it worked. Instead, they needed an imaging modality able to see the heart move in real time. Obstetrics could not use X-ray to image the growing fetus because of its teratogenic effects. Ultrasound removed this problem and provided incredible information about the growing embryo and fetus. But why didn't other specialties use it? One reason was politics. Physicians already using ultrasound sought to keep the technology and the potential income that went with it to themselves. Another reason was simple logistics. Ultrasound systems were very large. They often required dedicated space to operate. An example of this is seen on the image to the right. This is an ultrasound lab from the early 1970s. The history of pediatric ultrasound is similar to that of ultrasound as a whole. It arose from many of the same ultrasound techniques used in adults but applied to a pediatric population. It quickly became apparent that ultrasound was superior to the imaging studies previously ordered to evaluate these patients. In 1975, at the Society for Pediatric Radiology, an informal meeting of pediatric sonographers occurred. After a more formal session years later, the American Institute of Ultrasound and Medicine, or AIUM, finally instituted a pediatric ultrasound section in 1981. From there, a broad range of pediatric-specific applications emerged. Between the mid-1970s and the mid-1980s, there were a large number of scientific papers, books, and courses regarding pediatric ultrasound. These all formalized the sonography of the neonatal brain, the pediatric heart, the biliary system in the jaundiced infant, as well as the pediatric chest. But as in adult ultrasonography, the expertise was maintained solely within the ranks of the pediatric radiologists and cardiologists. However, over the last 2 decades, a number of specialties have begun to use the technology at the bedside as a core component of their practice. So why did this come about? The easy answer is that the technology has become more accessible. The main drivers include the miniaturization of ultrasound systems and the subsequent decrease in cost. In addition, the increased computing power has dramatically improved resolution, as we can see here as we compare 1970 to 2002 and then finally to present day. The entire infrastructure of how ultrasound is provided has also radically changed. A dedicated radiology suite is no longer a necessity. Instead, ultrasound systems today can literally go anywhere, including the training room, where musculoskeletal injuries can be diagnosed and continuously followed, global health missions in remote locations that traditionally have little to no imaging capability, the battlefield, where troops need fast and efficient imaging tools for making triage decisions, or even off the planet, where size and weight are critical factors. Another watershed moment for point-of-care ultrasound was the 1999 Institute of Medicine report on patient safety, entitled "To Err as Human, Building a Safer Health System." In this report, it was stated that an estimated 44,000 to 98,000 patients die annually from medical error-related causes. In response to this report, the Agency for Healthcare Research and Quality, or AHRQ, a division of the U.S. Department of Health and Human Services, published a response titled "Making Healthcare Safer: A Critical Analysis of Patient Safety Practices." One of the key recommendations of this report was use of real-time ultrasound guidance during central line insertion to prevent complications. By 2010, emergency medicine training programs were required to teach residents to competently perform ultrasound to evaluate patients and assist with resuscitations and procedures. While ultrasound is not formally incorporated into the core content of pediatrics residency, it is presently listed in the American Board of Pediatrics Core Content Guidelines for Pediatric Emergency Medicine Fellowship Training, and questions related to emergency ultrasound appear on the subspecialty certification examination for pediatric emergency medicine. Adding ultrasound education at all levels of emergency medicine and pediatrics has the potential to benefit the next generation of medical trainees and their patients. This momentum led to the first policy statement regarding pediatric point-of-care ultrasound, which was published in the Annals of Emergency Medicine in April 2015. This policy statement includes the following recommendations. Number 1, pediatric emergency physicians should be familiar with point-of-care ultrasound. Number 2, pediatric emergency physicians who use ultrasound should be competent in point-of-care examinations that are specific and relevant to their clinical environment. Number 3, a process should be in place for educating and assessing skills, quality assurance and quality improvement, and maintenance of hospital privileges. Number 4, pediatric emergency medicine fellowship programs should have an ultrasound education curriculum and competency assessment. And number 5, we still need standardized, universally accepted criteria defining point-of-care ultrasound, which will eventually be developed by national organizations such as the American Academy of Pediatrics, the Society for Academic Emergency Medicine, and the American College of Emergency Physicians. Despite the immense and growing popularity of point-of-care ultrasound, it still begs the question, is there any evidence to support the use of ultrasound by clinicians? The short answer is yes. There have been thousands of papers published on the topic in the most prominent medical journals in the world. Now for fun, let's consider a paper published in the American Journal of Cardiology in October 2005 titled, "A Comparison of Effectiveness of Hand-Carried Ultrasound to Bedside Cardiovascular Physical Examination." This study was carried out at the world-famous Cedars-Sinai Hospital in Los Angeles. In this study, a group of first-year medical students using a hand-carried ultrasound system with 18 hours of echocardiographic training were asked to identify cardiac pathology in a group of patients with pre-existing disease. Their findings were compared to the findings of board-certified cardiologists using standard physical exam skills using auscultation with a stethoscope. The results were staggering. The findings of the study showed the group of first-year medical students to be vastly superior in their ability to find cardiac pathology as compared to the cardiologists. Nevertheless, many clinicians simply say they don't have time to perform ultrasound studies with their patients. But stop a minute and consider the traditional paradigm of acquiring important data from an ultrasound examination. In this paradigm, the following sequence of events occurs. The physician needs imaging data to answer a clinical question. They order an imaging study. Another department takes the order and performs the test based on predetermined protocols. The data is collected, formatted, and presented to another physician, usually a radiologist. An interpretation is made and recorded, and then finally the recorded information is sent to the ordering physician. The subsequent time it takes to go from the treating physician's need for information to receiving it is very long. By contrast, when the clinician is empowered with the ability to use ultrasound at the bedside, he or she can immediately acquire information, explain it to the patient while doing the exam, and perform additional studies based on the findings of their exam. This goes a long way to improving efficiency and patient satisfaction. Okay, but some physicians will still say, "Why should I do the exam? Radiology will do it for me." Well, first of all, what if ultrasound services are not available when you need them, say at 2 o'clock a.m.? Also, radiology-based ultrasound will likely not have the capability or interest in performing a number of the examinations listed on this slide, many of which are critical to your work with patients. And in many locations, ultrasound techs and radiologists may be uncomfortable performing a pediatric-specific application for the evaluation of appendicitis, intussusception, and pyloric stenosis.
So Jeff, tell me what's different about examining children with ultrasound as opposed to adults.
So Tom, that's a great question. What we find is that pediatric ultrasound is not simply a duplication of ultrasound, but in smaller patients. These pediatric patients are actually more amenable to scanning, but they also have different physiology, different body characteristics. The disease pathologies are different. We're doing scans such as intussusception, pyloric stenosis, appendicitis. But overall, pediatric ultrasound is extremely gratifying.
Getting through these series of lectures will be a real challenge. These will introduce completely unfamiliar concepts requiring you to think differently and creatively. On the flip side, by the time you complete this online course, you'll find that the breadth of your ultrasound knowledge will be remarkable. By the end of this online course, you will promptly identify this 5-year-old source of hypotension after an MVC. You will be able to discern the cardiac view and estimated ejection fraction in this 3-year-old who collapsed at a playground. For this 4-year-old with wrist pain after a fall, would this ultrasound be concerning? Is there a fracture, or is this simply a case of discharge and reassurance? When a 4-week-old arrives to your ED with vomiting, this scan will allow you to make an informed disposition without waiting for an 8 a.m. radiology scan. Based on this scan, you will know definitively whether you should sedate, then IND this toddler with soft tissue swelling. For a 14-year-old with undifferentiated abdominal pain, you will recognize this structure and make the diagnosis rapidly and at the bedside. When an 8-year-old arrives after a bike wreck with shortness of breath and some chest pain, your bedside scan will inform your management even in the setting of a negative chest x-ray. And when you are caring for your sickest patients and desperately need IV access, you will have the tools to secure an IV sonographically. In closing, Third Rock Ultrasound continues to present ultrasound education both in live courses and on the internet with an expanding selection of classes. The Pediatric Ultrasound course is the latest offering from Third Rock Ultrasound.